To over 26,000 families. Since 2016, she has been working exclusively in neonatal intensive care unit and high-risk follow-up clinic. Besides focusing on developmental care in NICU, she is actively involved in manpower training and research. She and her colleague Ushma volunteer to mentor therapists through webinars and run a discussion group on WhatsApp. Thank you, Puja. I congratulate you for one thing that you have come back to your homeland, India, and working with our children. Thank you for that.
Thank you, sir. Thank you very much. It is my most intense pleasure today to introduce our speaker for today's webinar. Dr. Ushma Goradia is the founder and director of Active Karya, which is a clinic based in Bangalore. Her practice focuses on providing comprehensive rehabilitation services for pediatric patients and individuals with neurological conditions. Ushma and I, like Sir just mentioned, we've known each other for a while, so it's very difficult for me to read a very formal, introduction. But her work is so impressive. She has over 35 years of experience in pediatric therapy, ranging all the way from early intervention services to school-based therapy to outpatient centers. Out of these 35 years, she spent 17 years in the United States and has, similarly moved back to Bangalore to work with children here now. She has a bachelor's from Mumbai and a master's degree from New York University. She also went ahead and got a doctorate in physical therapy from Rutgers, which is a institution in the US. Around that time, she also got her certification in sensory integration through the University of Southern California. This is a gold standard program that equips therapists with advanced skills in treating sensory processing disorders. Ushma also has previously held board certification as a pediatric specialist through the American Physical Therapy Association. This recognizes her expertise in treating children with complex development and neurological needs. Through Active Karya, Ushma continues to make a meaningful impact in the lives of children and adults. And as we again mentioned before, she's a great mentor, to not only me, but a lot of budding therapists, experienced therapists, because it's always great to learn from, her experience. So I welcome Ushma today, and I'm looking forward to learning from her. Thank you.
So, thank you everyone for your kind words. I am very happy to be here. I am, thankful to the Indian Academy of Cerebral Palsy and specifically to Dr. Mallikarjun and to Vidya for inviting me as a speaker here. And thankful to all the audience who gives credit to Williams.
I'm sorry to interrupt. Could you speak little louder?
Yes, sir. Yes, sir. Okay. So here, if you see the pyramid of learning, you see the 8 sensory systems at the bottom, and then at the top, you see your activities of daily living. You have behavior, which is age appropriate behavior in the social context. And then you have academic learning, or which means learning anything in life. Now, in order to go to the top of the pyramid, you need to address everything at the bottom, which is the sensory systems, that is a foundation of all childhood development, upon which there is sensory motor development that occurs in 0 to 2 years. And then there's perceptual motor development. So please keep this in mind. I would strongly suggest everybody here to look at this pyramid of learning in detail. It's on the internet, you can find it. Okay. So now, out of the 8 senses, I'm going to focus on 4 senses, which are called the power senses. According to Dr. Jean Ayers, who came up with this idea of sensory integration, according to her, the power senses are the 3 senses: vestibular, proprioception, and tactile. Now, as a clinician, I also bring in visual perception because I see that children, almost, many children whom I see have visual perception issues. Even the literature says that 45 to 90%, anywhere from 45 to 90% of the children with developmental disabilities have visual perception issues. And we also have to keep in mind that the occipital lobe does not deal with vision only. The occipital lobe also is connected to 70% of the rest of the brain. So it can be called as a multisensory, lobe, the occipital lobe. And therefore, I bring in vision perception into my treatment. So remember, the vestibular, the proprioception, and the tactile, these are the power senses, or the big 3, as per Dr. Jean Ayers. And for me, it is also vision perception. So why are these important? Because if any of these senses or any of these sensory systems are not working appropriately, then the motor output will be difficult. The motor output, remember, that is what we physiotherapists deal with, motor output. We always talk about motor impairments, motor control. We talk about that. So now all these systems, as far as we are concerned, all these systems, the vestibular, proprioceptive, and the tactile, relate to weight bearing and weight shifting, something, that we do day in and day out in every session with our children. These systems are also responsible for writing and equilibrium, postural control, and then not to forget that many primitive reflexes that we see, primitive motor patterns, they are mediated by the vestibular system in conjunction with proprioceptive and or tactile. Okay. So now coming to tactile, because skin being the largest organ, tactile sense is very important to us, because early in infancy, an infant receives early input through the tactile system because, skin is the largest organ. And, when the infant is about 4 to 5 months, the infant starts, bringing, even early on, bringing hands to midline. The infant brings, hands to mouth, hands to knees, hands to foot. So all of these behaviors, they contribute to something what we call as body scheme. Body scheme means mapping of the extremities. We know our brain knows where our extremities are. And tactile processing is very important. By 4 to 5 months, if the infant has not experienced this extremity mapping, then it can lead to deficits in motor learning. This has been demonstrated in the literature by research, and we see it daily in our clinical practice. Now, coming to vision perception, there is something called midline tracking. How do the eyes move? There is visual fixation, there's midline tracking, the child reaches out, the infant by a certain age reaches out, for objects, and that is how they map the environment to the body. They understand the relationships between the environment and the body. So all in all, you have to understand that these sensory systems do not work in an isolated way. They work together, and and that is why it is called sensory integration. The senses are put together so that the child can function in their daily life. Okay. Now, so why are we talking about sensory, because mostly physiotherapists say that, oh, there are sensory issues, or there are issues with, midline, or there are issues with vision perception. Let's refer them out to an OT, and which is fine. However, in many areas, we don't have occupational therapists. And the other reason why I would strongly urge physiotherapists to at least be aware of the sensory systems and recognize the differences or the dysfunctions so that you can refer out to an OT, or there are many things you can do by yourself, you can incorporate into your practice. But then the first step is to understand the sensory systems and be aware about them. And the primary reason is that motor cannot exist without sensations. Sensory systems and motor systems work in tandem with each other, they are interdependent. Sensory input is necessary for motor output. You have to remember that. And then, more importantly, sensations affect motor response, behavioral response, and cognitive response. I could give an example of this, but we are running out of time. So if we have time, I can give many examples about this. Um, if, comfort levels to sensations, they affect our emotional regulation. So for example, an infant, a baby, naturally we rock the baby is swaddled. And if the baby is irritable, but if you swaddle the baby and rock the baby, the infant calms down. That is the behavior. So what sensation, sensory input did the infant get? Tactile and proprioception from the swaddling, and vestibular information through the gentle rocking. And then the infant calms down. So comfort level to sensation is very important. If there is discomfort with the sensation levels because the sensory systems are not processing very well, then it could lead to triggering the sympathetic nervous system. That is, the heart rate goes up, the respiratory rate goes up, and basically there's an autonomic trigger. It triggers the fight, flight, and the freeze, whatever we call. It triggers the sympathetic system. Okay, so that is something we have to recognize when we treat a child, that you can trigger the sympathetic system very easily if you're not aware about the sensory systems, when you are doing the motor techniques or the motor approaches. Okay. All the conditions that we see, of course, not all, very few I have mentioned here, but by and large, we see children with hemiplegia, we see cerebral palsy, spastic diplegia, global developmental delay, we see preterm babies, we see Down syndrome. Now, just think across all these conditions. In hemiplegia, we see very commonly unilateral neglect and visual neglect. So as I said earlier, we have to keep this point in mind because the occipital lobe connects with 70% of the rest of the brain. So thereby it becomes very important that we think about it. When we see altered muscle tone, you can say that the child is not receiving appropriate proprioceptive input. We see postural stability, we see bilateral coordination issues, and we think about all of this as either muscle weakness or muscle spasticity or hypotonia. But there is another piece, that is the sensory piece. How are the sensory systems working with this child? And why? Because when we talk about lesions in the motor production areas, in the conditions that mostly we see, lesions in the motor production areas also affect the sensory processing areas, because then the brain works like a circuit. The brain parts, the brain centers don't work in isolation. The brain works as a circuit. Therefore, when we have lesions in the motor production areas, it also affects the sensory processing areas. There is enough, research and, literature which says that children with neuromotor impairments, whom we see, they frequently demonstrate sensory processing dysfunction or differences, the SPD. Okay. Furthermore, most of our children do not move. They do not move adequately. If they do not move adequately, they don't have opportunities to explore and interact with their environment. And this leads to secondary sensory processing deficits. So please remember that all the children whom we see, besides their neuromotor impairment, they also have sensory processing differences or sensory processing dysfunctions or deficits. And these deficits could be either primary or they could be secondary. Okay. So as physiotherapists, we know that movement is the key to not only motor skills, but it is also the key to development of cognition and social development, which becomes very important, in today's world, that, a child needs to be a part of the society, to whatever level they can participate in society. So when we talk about movement, we think about motor, but think about movement as sensory movement. As soon as you think about movement, think about the vestibular system. In my clinical practice, I heavily stress on movement because, again, Dr. Jean Ayers postulated that the vestibular system is a unifying system. The vestibular system, basically all other sensations, so except for the olfactory, all other sensations that you talk about, the auditory, the proprioception, the taste, all of the touch, all of these sensations are processed in reference to the vestibular system. We have to remember this. And that is why movement becomes very important. The vestibular system goes directly to the cerebellum and then to the motor areas. It does not have a dedicated area of the brain like the other sensations have. Thereby, the vestibular system basically connects to all of the brain. You have to remember that. And that's why movement is very important. In your treatment, when physiotherapists are treating children, um, they always complain to me, oh, the child is crying, the child is not cooperating. If the child can walk, let's say Down syndrome or certain conditions or hemiplegia, the child runs away from the therapist or from the therapy room. The child is uncomfortable on the therapy ball or the balance board. The child is fearful of negotiating staircase, going up or going down. So we think of all this as, the lack of cooperation as a behavior, or, oh, the child is not comfortable with us. But I would like to say, think, why is the child not comfortable with you? The child possibly may be hyper responsive to touch. Okay. And therefore, they exhibit their discomfort. The therapist's touch is uncomfortable to them. They can only tolerate their mother's touch because the mother is, staying with the child 24 hours a day. So before you handle a child, don't just go and, start doing your therapy. Get the mother into the picture. Particularly, this becomes important when the child is a baby in the first year of life, in toddlerhood, even in the second year of life. Before even touching a child, get the mother to do it. And you'll see that in my videos. Okay. Involve the mother, teach the mother. This is where the parent education comes. Okay. Again, during our therapy, when we do our therapeutic activities, the position of the child changes, right? We put the child in prone, we put the child in side lying, we put the child on a ball, we put the child on a wobble board, and the child cries. The child could be hyper responsive in the vestibular system. The child may have gravitational insecurity. Even if the child does not have a classic, what you call the GI, what we call classic gravitational insecurity, the child would still be afraid of moving in space. This is a vestibular issue. Okay. Talking about stairs, If a child does not want to climb up or does not want to climb downstairs, we think of it as a balance issue. Fair enough. However, the child may have depth perception issues. Their brain may not be appreciating how much the depth is, and therefore the child is fearful. So consider the vestibular, the proprioceptive, the vision, and the touch systems when you treat a child. If the child is crying, let the mother do it. You have to win the confidence of the child. You have to win the trust of the child. It may take a couple sessions, few sessions, sometimes even a few months, but the child has to be comfortable with you, because if not, in my earlier slides I spoke about, it can trigger the sympathetic nervous system. Okay. And if that happens, the child is crying, then your therapy is not going to be productive. Your sessions are not going to be productive. So therefore, physiotherapists need to be aware of the sensations, the sensory integration, sensory processing. So far, whatever in the short time I have spoken about. Okay. So let me show you a video. I hope everybody can see it. So here, I also feel this is an 8-month-old child. I work on sitting balance. And yeah, I could have put the child on the ball, but what I do is here the mother is sitting on the ball. Mother is sitting on the therapy ball, obviously with feet well supported. The child is sitting in the mother's lap. Okay. So we are working, on balance. Okay. I also want the child to be comfortable with movement. And then the other ball that I've given, this watermelon patterned ball that you see here, just look at the child's hands. See how he's trying to feel the ball. He's trying to feel the patterns. And maybe in the next session or down the road, I may give them a textured ball, a little harder ball or something like that. But what happens if if you don't give the ball, then just sitting on the ball may not make too much impact. I mean, just sitting in the mother's lap and the mother is sitting on the ball, you are working on balance. That is your goal. But that may not have that much impact. You can increase the impact of your treatment. You can maximize your outcome. So here I've brought in hand function for this child, right? So I've brought in tactile for this child. See, he's trying to grab the ball. Okay, but the ball has a smooth surface in this session, so he cannot grab, but he's trying his best to feel with his hand. So there I bring in tactile and the hand functions. Okay. This is how you can bring the sensory into your treatment. Okay, sorry, I need to change the slide. Okay, so what are sensory flags in all the conditions that I mentioned earlier? You see asymmetrical posture. We may be thinking, as physiotherapists, we may be thinking that the asymmetrical posture has to do with increased weakness on one side versus the other, or something like that. I would also add in midline issues. Midline issues means the child has issues with keeping in midline. And this, I'll give an example of, some of the adult hemiplegic patients that we see. How they push towards one side. They are pushing because they also have midline issues. Okay. The pusher syndrome that we used to call earlier, I don't know whether that term is in use anymore, but I still see people with hemiplegia, many of them, they just keep pushing on one side, like this. They have midline issues. So the same with our children. If you see asymmetry in posture, I would also think about midline issues besides the muscle weakness and balance and everything. There are issues with balance with all our children. They are fear of movement. They are fear of, stepping up and down. They are fearful of jumping. They are fearful of climbing. Basically, all of these are feet leaving the ground. So again, it's a vestibular issue. They're not processing vestibular information, efficient. You see issues with body awareness and body spatial awareness. So body awareness is if you ask them, bring hands to midline or touch your knees or touch your head. they may not be able to do that most of the time. Body spatial awareness is if we sit them on a bench, they may sit very much forward on the bench or maybe on one side of the bench. They may not be centered on the bench. Okay. This is body spatial awareness. And then many of our children with cerebral palsy, global developmental delays, Down syndrome, all these conditions, we just observe them closely. Head shaking is quite, frequently. They display restlessness also, although they don't adequately move, but they display restlessness as they grow up to be like 4 years, 5 years, and 6 years old. Impulsivity, very common in children with hemiplegia. There are reasons for that. Okay. Their hand function is very poor. They don't hold things in the hands, even if you give them, or they may drop things, or sometimes they withdraw their hands actually, if you give away to hold on during your treatment. That's called tactile defensiveness. And then, of course, the decreased eye contact we see, and then the visual perception and the depth perception issues that I spoke about earlier. Now, so, the first step is to recognize these sensory issues and the sensory flags in all our children. Because if you recognize something, then you can go on to, introspect and identify. So that then leads you to providing a holistic intervention. What can I do with this child? These are the sensory issues along with the motor impairments. How can I plan my activities? How can I design my treatment? What can I do? Okay. To get better and faster outcomes of therapy, because that is the need of the hour. We need to get better and faster outcomes of therapy. And then if there is something that I cannot handle, yes, refer out to an occupational therapist or talk to an occupational therapist. Basically, the idea is you have to be the best therapist that you can by providing a holistic, comprehensive approach of treatment. Okay. So let's go down some of the therapeutic activities that we commonly do in our clinical treatment. We do prone weight bearing. So when you do prone weight bearing, you may be thinking of it as a motor task. That you are strengthening the upper body or you are strengthening the neck extensors. I also think of it as vestibular. Yes, motor is not forgotten by me. I am a PT. I'm a pediatric PT. That is my strong foundation and my background. However, besides a motor, I also think of prone as a vestibular position. So prone as a position to get vestibular input or vestibular information. Okay. Uh, yeah. So straddling a bolster and trunk rotation. How would I, besides the motor part, I would think about you are changing the visual field from left to right and vice versa. You're rotating the trunk, so you are changing the visual field. And, that is very helpful in your daily function. Okay. When you use the wobble board for balance, again, balance is vestibular, but you can combine some fine motor or something else. You will see my videos. I want to show more through my videos how I treat my children. Gait training as you're walking, with a walker, with your assistance as you're walking through the room. The child gets to see different equipment, different people. Basically, the child is moving through space, and that gives, again, vestibular input and opportunities to interact with other people and objects. And stair training, I already spoke about that. You need the not only balance, but you also need depth perception, adequate depth perception. So as a therapist, be aware of the sensory components as you do your motor activities. Be aware of the sensory components that come into play as you're doing your therapeutic activities. Okay. So I would like to, say that performance of any movement, whether you're doing bridging or you're putting the child on the ball, or you're doing with something with the child in prone, this performance of that activity in isolation is not enough. In 2013, Lobo and other authors published this very good article the heading I have put it here. Physical therapy cannot just be about motor skills anymore. It has to be grounded perceptual motor experience. So what is grounded perceptual motor experience? Perceptual motor experience means you're teaching the child how to connect the sensory experiences to the motor actions. Okay, and that is what happens in our daily life anyway, and that is the reason we are treating the child. So we cannot just focus on only motor, we also have to focus on the sensory part. Only then you get a perceptual motor experience. And so how can you, okay, I've lost it. Okay, so as I said earlier, provide opportunities to the child to interact with people and objects in their environment. Only then you will see improvement in participation in therapy, and you will see improvement in learning. Make your activities, enrich them, meaningful. Why meaningful activities? Because it creates to better neuroplasticity. Okay, if the activities are meaningful and functional. Play based, because the child's work is play. Okay, and fun is to motivate the child. So you can upgrade your activity many ways, through a lot of material, many ways: reaching for objects, transporting objects from point A to B in your near environment or in your far environment, fixing puzzles, throwing objects in a basket. And obviously always include movement, include some kind of visual component in it. And although working with hands is a function of OT, but I really, I feel that no, during our activities also, we can give hand materials to the child. You can look into your immediate environment. You can create and use a lot of hand materials right from your environment. Okay. Okay, so let's dive into the videos. Now, prone on the ball is something that everybody does very frequently. Okay, all the time it is done. So how can you make it enriching? How can you make it enriching? This is a child with hemiplegia. Sorry, and he also had sense.
Number two and flower. Number two and flower, which looks like flower.
Speech delays, all of it was there.
There is flower.
Recognize that the child had hemiplegia. In the background of autism, the hemiparesis was forgotten.
Ushma.
Down to up, the entire upper body, you see, and fourth arm, you can have it through the left.
Ushma.
Some pick it left, right. Thoda is taraf aa jaye.
But as I said earlier,
pick up with left hand.
Ushma.
Hit the child on the ball.
Ushma, can you hear me?
Take strong. King, K for king.
Can you hear?
So the video is also, there is audio with the video. So we couldn't hear what you were saying.
Yeah. Oh, okay. So I can, yeah. There's a difference. Okay, just listen to what I'm saying. Yeah.
Dimension number two. Dimension number two. And wait. 10 diamonds. Diamonds 10. Now there's a difference because this side is a little bit. Practice will come. Dimension number two. Dimension number two. This one. And wait. One hand down. So that way. Give it like this. Rolling. Is this holiday?
Okay, so it's not only the activity, but it's, I'm getting all your, the motor as well as the sensory component, the visual part. And I'm also educating the parent, what happens when he weight bears on the left side versus the right side. Because, parent education is also very important, because here the mother would have a question, oh, the left side is weak and you're having my child pick up the cards with the right hand. So parent education is also very important to build the, parents have to, trust us, learn to trust us and, gain confidence in us. Okay. My next video will be, let's see. Yeah. So this is a child with spastic diplegia. and he's rolling in a barrel. And here, as a physiotherapist, you can say, oh, he's working on his core, which is good because core is again related to the vestibular system, besides the motor that we speak of. But then he's transporting objects, from point A to point B. He's bringing some shape blocks, square, circle, whatever, colored, and then he's matching there. So again, I got vision perception and cognition in there. And then children who have speech, or speech also comes slowly when you introduce sensory components. In fact, sensory integration is very well known to improve speech. It has been demonstrated in research, and I see it in my clinical practice too. Okay. I need to move to the next slide. Okay, this is another child with spastic diplegia. So we are working on balance problem. I mean, taken, but she has a left side. So why stimulation facilitating her hand function on the left. I'm doing some sort of weight bearing on the left. I'm having her reach a little backwards and downwards using water bottles. This is the activity most children they enjoy in my clinic, and I use on the waste, right? Find them everywhere. So you just have to fill them up and put some color in there, and they give perceptive input as you pick them up. So here, as the child is moving backward and in various degrees and some in directions, getting the bottle, picking up the bottle and putting it on the table, they are getting vestibular information. Besides the motor work that is going on. And then she's speaking also, it's a yellow bottle or a green bottle, or this is very heavy, or oh, this is hard. And she's speaking to me, "Arey, ye to peene ka pani nahi hai." Just listen to her, she speaks to me,
करेंगे ना रोज रोज इसमें खेलने के लिए थोड़ी ना नया पानी करेंगे। चलो चलो दूसरा येलो भी रेडी है आपके लिए, येलो भी तो रेडी है आपके लिए।
And did you see how she shook the bottle? She's shaking the bottle. Why? That behavior I see all the children, they shake the bottle. They want to feel that feeling of heaviness, the perception that we call. And then obviously the grasp. Okay. So besides lot of trunk work, sitting balance, I'm also offering electrical stimulation. I have her left hand in the weight bearing position slightly. Everything is going on at one time. Okay. And then the child is obviously speaking to me also, or speaking to the therapy staff, okay, which is again a great thing. We don't do activities mechanically. We have to connect with the child. We need to connect with the child. Okay, I need to go to the next video. Puja, you have it?
No, I didn't receive the PowerPoint.
Oh, you didn't receive. Okay, I got it. I got it now. Okay. Need to yellow also. I'm having her do a functional activity. Very nice.
Ushma, can I interrupt for a second? So if you are speaking and there is volume on the video, we can't hear.
I tried to reduce the volume. So thanks for pointing. Okay. So here I'm having the child do bilateral integration activity. Basically, you just don't focus on her weak side, which is her left side. You have her use both sides of the body together for better neuroplasticity, function, etc. And when you give such tasks to children, like here when the what happened to the PowerPoint? I don't know why the PowerPoint faded.
I think it's like loading. Do you have the video separately, like not inserted in PowerPoint?
That also will take some time, to
Okay.
let me just finish this. I just have 2 more videos and then we finish it off.
Looks like it's buffering. So you might want to wait for a second.
It suddenly faded away. Meanwhile, anybody has questions, can you please ask? While we are waiting. Are there any questions in the chat box, Puja?
No questions, but a lot of people can't hear you very well.
Okay.
I can hear you fine, but
Sorry about that. I don't know. We are all ignorant at technology.
technology always gets us.
How many webinars we do and how
I
much
know.
get stuck up somewhere sometime.
Let me share some of the references while we wait.
So I have put up a list of references.
Yeah.
Share them in the chat box. Yes.
Yeah.
Yeah. Yeah, it's still loading. Does anybody have any questions? Please ask. I love to take questions. Because then only, we can do some brainstorming.
Oh, okay. Sorry, I missed one. How to develop sensory and tactile development.
How to develop?
Hmm.
I don't think I understand that question. So where is the question coming from? The child has tactile processing issues? Is that what you're asking me? Or okay, let me put it, maybe that is what the person is trying to ask, that, how, that they may have a child who has tactile processing issues, okay? So the thing is that if the child has tactile processing issues, they may be tactile defensive. They may also have oral motor issues, because what is oral motor? Oral motor is tactile in the mouth, okay? So what I do is, obviously you do many, many things, expose the child gradually to various textures of material, like things like, most mothers here give Play-Doh or the roti atta dough, that is made every day in the house. But what my child needs lot of variety of material, like play with rice, play with beans, play with sand, mud, stones, leaves, when you go to the park. But then again, that is only one part of the picture. If you're only providing tactile materials, that is where I would start, though, to gain confidence of the child. However, the very important thing to remember is vestibular information, all other sensations, including tactile, is processed in reference to vestibular. So again, I am again reiterating movement. I would give this child movement through swings. If you have no swings, crawling, jumping, climbing, stepping. Even when the child climbs a ladder, what do? The hand grasp, the foot grasp, the body awareness. Where is the foot on which part of the ladder? Where is the hand on which part of the ladder? You are also contributing to body awareness. So I would say that, you can't work on a single system. If the child has tactile processing issues, the child will have issues in one or two other systems as well, because remember my words, the brain works like a circuit. Systems don't work in isolation from each other. Neither the sensory systems work in isolation, nor the sensory systems work in isolation on their own.
Yeah.
This is very crucial for everybody to understand. So,
Yeah, good point.
my clinic, I don't even give rice and beans and things like that. But I tell people to work at home. I have suggestions to work at home. But yes, in the beginning, I may give that to the child to gain trust from the child. Okay, because remember, The child has to be comfortable in our clinical environment. If the child is not comfortable emotionally, your session is not going to be productive. Okay.
We have another question. One child has monoparesis, hand function is not proper. When I treat, she always cries. If the parent touch the hand, she also cries. So how do I develop movement?
Yes, so this is monoparesis. So, children with monoparesis or hemiplegia are known to have serious tactile issues. And it goes back to, that the movements of that hand to knees, hand to foot has not happened. And therefore, tactile defensiveness. There's a scientific reason for that. Actually, I have no time to explain everything in detail. So I would say that, encourage the parent to sort of have, touch the child firm but gently. Start with touching the child firmly but gently. If the child has, some sort of spasticity or increased tone, the child would be fearful that the adult is trying to prise open their hand.
Hmm.
And thereby the child, maybe many adults in the past have done that. See, we don't know the history. Even parents do that, Are ye haath nahi kaam kar raha hai, chalo isko kholo. They try to forcefully pry open the hand. And I think these behaviors from parents or adults or anybody else should be discouraged. You have to go in very gently. If the child is not tolerating, the skin touch from the parent, I would suggest the parent to wear something like what I would say is I suggest parents to wear old socks. Why old socks? The foot socks that we wear, the socks and shoes. Why old socks? Because old socks are worn out and they are slightly rough, but they are soft. So I have the parent wear the sock in their hand and gently but firmly, stroke, whichever, if the forearm or the arm, or I would even go back up to the, scapula. To see if the child, is comfortable there, would start with there and then come down distally, rather than just working on the hand um, initially. This is what I would do. Yeah.
Can I just also suggest swimming?
Ahead.
It's a wonderful way to get some of these things going. So Ushma, we have quite some questions. If you want to stop sharing, we could just take
Okay.
Q&As. Yeah? Okay. So here, I'll go to the next one.
Hmm.
How do we differentiate between sensory issues and behavior problems? Sometimes the child might be over pampered by the parent, or when, you know.
Okay, sensory issues and behavior. That is what they asked.
Mhm. How do you differentiate between the two?
How do you differentiate? Yeah. Okay. Pampered. So, pampered, if the child is pampered, or what I would call is the child is overprotected. Okay. There, if you give the child whatever they want, they will calm down. Okay. But if they really have real sensory issues, you have to try a lot more, give this, give that, try this, try that before you really get into something. If the child is truly protected or pampered, they will easily, cooperate with you once you give them what they want. And give them what they want, meaning it could be their favorite toy, their favorite food, snacks, chocolates. Although I discourage my parents listen to me, but I know that many parents, just give the child a chocolate biscuit or whatever, or, tell the child, oh, you know what, do this. I will give you ice cream. I will give you chocolate, something like that. That is the first thing I would, Also, I would look at the child's face, that is what we are taught, right? As therapists, you look at the patient's face, is it flustered? Is the child, you can make out from the face, that the child has increased heart rate. Look at their chest and see if they're breathing slightly heavily, then you have already triggered, some sort of sympathetic response. So then you want to back off. There it's truly a sensory issue. Okay.
Yeah, I agree. I feel like, the behavior issues don't always have a physiological sign, but if you overwhelm the sensory system, you might see some of those, you
Logical,
know,
you
yeah.
see symptoms immediately. Yes. Yes.
I mean, for us, for me in the NICU, that's my, hard line. There is, you don't cross that. You
Yes.
see some of these dysregulation patterns
Yes.
and you don't cross that. So
Yes.
yeah,
Yes.
yeah.
And actually, a NICU it is even more because the child is younger or, in infancy,
Mm,
a toddlerhood also. But even if the child has crossed 3 or 4 years age, you can really see the sympathetic signs when the sensory systems are affected with what you are doing in your clinic right now. Okay.
yeah, yeah.
And that is your point of guiding them.
Right. So
Thank
we
you, ma'am. Thank you.
You're welcome.
so this question I find it very interesting. The question is sensory processing needs time. So how do you handle that? I guess they meant maybe with the parents. How do you discuss that with the parent?
Yes, I do. I do. My parents are quite involved in, with me because I strongly believe that therapy is not something where the child walks in, we as therapists do something and the child walks out.
Yeah,
That is just not acceptable. Um, Earlier, I used to let parents in, earlier meaning just until the COVID, I used to let parents in. Parents would help me with therapy. As you saw in the first video on the prone on the ball, I'm explaining to the mother. Now, because situation has changed in my clinic, I don't let parents in, but still it is transparent because there are curtains between the waiting room and the clinical area. That is one thing. The parents can also hear what I'm doing and make out what I'm doing. And then I call the parents, inside. If not every session, I call them frequently in when the child is doing something very nice and I'm very happy about it. Or if the child is not, things are not going on as what I wished. So I try to brainstorm with the parent, what's going on in the family, or is the child hungry, or, did the child have antibiotics, or, recently, or, many, many things. And then I'm always answerable to parents. And if I don't, so basically, parents trust me a lot, and I invest a lot of energy in gaining the trust of the parent because, if you don't involve the parent or the family, therapy does not get good outcomes. This again has been shown in research almost 15 years ago.
yeah.
Okay, you have to involve the parent. And and of course, I run a YouTube channel. I write blog posts. So through that also, I educate parents a lot. Parents have to be educated, without using the therapeutic jargon. And then I give a lot of suggestions to parents, what to do, why. And then parents also, because if they have gained trust in me, they ask me questions either on WhatsApp and I say, oh, next session we will discuss, or I'll call you in the evening or something. And I try to dig deep into it as to how to make the child do something or, reduce that particular behavior at home. Try this strategy or that strategy. Okay.
Yeah, I just wanted to add one point about this because I feel like um, there is a sort of an underlying vibe to therapy, which is like you go and you want something out of it immediately, which a lot of times with SI doesn't work like that. But this is where we need to also use our judgment as to how far we are pushing the child. So the example, the video that you had with the mother sitting on the ball with the child will give you a noticeable change in the function,
Yes.
I mean, a noticeable to a parent, to a layman, change in function faster because this child hasn't cried. The child
Yes.
has actively participated in
Right.
in whatever is happening around them, and that also, I think, more than anything verbally you can say to convince the family, if they observe that their child is different within 2 3 weeks, I mean, that just like you said, it builds that rapport, and that's it, game over. You got them.
Yes, I mean, until there's no formula in our field, okay, that's what I tell parents. There's no mathematical formula.
Yeah.
However, at least until when they are babies, 9, 10, 11, 12 months, I'll be honest, I don't even touch the child. I have the
Mm,
mother next to me and I tell everything to the mother, do this,
right, right.
way. I will put out toys or, put out things so that the child is enticed to do, but everything is about the parent education. And more so because the same thing, they can go home and do it.
Hmm, hmm.
The carryover program.
Drive program. All right. We'll take another one. Um, I think, most of your presentation has answered this. How does sensory processing impact a child's motor development? But if you want to maybe just give a two-pointer answer to this.
Okay. So sensory development, meaning, okay, so sensory input, right? I'll give you an example. Right now, you are in this webinar and you're very attentively listening to me or what's going on here. Somebody in another room in your house starts making a big noise, or your child does something, or your child cries. What is your first motor response? You will turn your head, maybe even turn your body to see what's going on over there. You may even get up and walk over there. That is your motor and your behavioral response to see what's happening. And then on a cognitive level, you take a call whether what to do with your child crying, give them to the
Yeah.
father or give them a toy, or at a cognitive level you will think that what to do with this crying child right now because I have to attend this webinar. Okay, so you got your motor, your behavioral, your cognitive response. Okay, I will give you two classic examples. Again, when people are in a classroom or in a webinar like this, you will filter out all other sensory information, what is going on outside on the road, on the street, outside your door, just to listen attentively to the person who is speaking. So you're screening out the auditory information from the rest of the world. You're only listening to the auditory information, to the speaker, for example. But the same auditory information takes a priority when you're crossing the street, particularly when you're crossing the street with your child. Even if your child is crying, you will just hold the child's hand and drag the child so that you are safely able to cross the street. You are listening to the honking of the cars. You are scanning the environment left and right. In a country like ours, vehicles come from both sides, no matter where you are. So you will scan the environment, where are the vehicles coming from. Your goal is to cross the street that time. So you will pay more attention, priority on the auditory and the visual information. And you'll just drag your child, even though your child is crying. Okay. So sensations in different situations, different contexts take up, priority, okay. So that we can function efficiently in our world.
Right.
We can function efficiently in our world.
Okay. Um, this is another question. I have found some parents say my child is quite okay during sleeping, but when they get anxious, their hands get twisted. So, how do I deal with that? I'm not very sure what it means, but maybe they are fiddling with their fingers or.
Their hands, fiddling with their hands, again, I see as a coping mechanism,
Mm,
which you and I also do that if we are in a very, very troubled situation, for example. You and I, meaning all adults, do that. Okay.
yeah,
Right. The difference is that we come out of that situation, because we think cognitively, oh, I should not be so afraid. Okay. All right. And we stop that behavior. But children who have true sensory issues can't. So this is one of their coping mechanisms that I would say.
right.
Okay. Sensory issues, what parents complain, like hand flapping, toe walking, laughing. I mean, so many sensory issues that, parents complain about. They are
Yeah,
related to multiple sensory systems at one time. And also their coping mechanisms. So let me explain. Adults, all of us here who are watching, we also, I shouldn't say sensory issues, but we also have coping mechanisms. Like, during a meeting, people will,
twirl
uh,
their hair.
fidget with a pencil, or, twirl their hair. Or if you're too tired, you will go out and, you will stare outside your window or balcony for some time. So you can call them coping mechanisms. Your system has to cope up, in order for you to function. The difference between us adults and the children whom we see is that we come out of that behavior. Okay. You may stop fidgeting with a pencil within 2 minutes, 3 minutes, or you may stop staring out of
Yeah.
the window and then come back to your work, return to your work, resume your work. Okay. Child does not do that. And when the child does not do that, then it becomes an interference. The sensory issue becomes an interference for the child to participate in any kind of
Mm-hmm.
task or learning or engagement.
Right. There's a similar, question keeping to this theme that a child who keeps rubbing their private
Mhm.
parts or, on pillows. So what could be done, whether
Yeah.
it is sensory or behavior?
It is a sensory. So this has been my observation that around 6 to 7 years of age, children, start rubbing on their private parts. They are seeking, sensory stimulation through that part because um, that body exploration has actually not happened back in time. It should happen by 2 years of age. It has not happened then. Okay.
Mm,
So I would say body awareness is still a work in progress. Remember, I said, body awareness. Body awareness is just not asking the child to point out where is your head, where is your nose, where is your eyes. Body awareness is actually forming, the motor maps and the sensory maps in our brain, right? So, for all the children whom we see, the body awareness has not been developed very well. And in my experience, I see that, around the age of 6 to 7 years, they have this behavior. And just today in my clinic, I was talking, with parents, with a girl who does this in school. So the only thing is you can give them strategy. She's a little girl. So I said, make her wear very tight shorts, lycra shorts, which shorts, lycra shorts, which, the lycra gives that elastic feeling around the thighs and around the private parts. Okay. I said, let her have, let her sit in a bucket during bath time, sort of curled up. Let her be there, for 20 minutes, 30 minutes, enjoy her bath. Let her, teach her how to wash and clean her own private parts because now she's 6 year old going on to 7. So that way, she explores her own body. And the other thing today I came up with, which I have to be honest, it didn't occur to me all this time. But I said, why don't you do ball squeezes, an 8-inch soft ball, you squeeze between your distal thighs, that means you're working on your adductors, but then adductors also connect to the pelvic floor, right? So if you're squeezing a ball as an activity or as an exercise, many repetitions, it probably gives deep input to
mm,
your pelvic floor and
right.
lower abdomen. At the same point, I would say, do TheraBand exercises for the hip abductors, the complementary exercise.
Right.
These are the
Um,
things I gave them.
yeah. So I'm just going to take 1 second and check in with sir if we, I think, have a